Georgia, and he has a 6:30 flight, so we have to make sure that we don't miss him. You're going to enjoy this. This whole camp is about what? Prevention. And Dr. Reid is going to share with you why it's so important that we get real serious with these amazing bodies.
Thank you, everybody. How are you doing this afternoon? I know you just had a scrumptious and delectable meal. And if you are at all tempted to nod, please don't do that. Feel free to follow the evidence-based studies of standing before nodding. And often in my classrooms, even when there were amphitheaters and students were sleeping, I would walk up the amphitheater while I was lecturing and stand right beside the student until that person woke up. Or I would call their names or ask questions. But certainly, you've made an investment to come here in your time, in your means, maybe even your taste buds that have to get acclimated to your experience here. So we want you to get the most out of this experience. Can I get an amen? Amen. The back table, can I get an amen? Amen. All right. So can you please repeat after me? Get serious. Get serious. About prevention. About prevention. I don't know if I believe you. Let's try it again. Get serious. Get serious. About prevention. About prevention. All right. So let's talk about the leading factors that lend themselves or lend us to disability. How many of you like disability? Raise your hand. Okay, you're paying attention. No one raised their hand. I don't like disability either. This was a huge study that investigated hundreds of diseases as well as scores of risk factors all around the globe. Countries, developed countries in the OECD, 34 countries, as well as the United States. And this study looked at data from 1990 to 2010, and they looked at risk factors that cause disability. And this is a specific term, disability adjusted life years, daily, we call them. And the risk factors that they found began with number one, dietary risks. Did you enjoy your lunch? Yeah, your lunch was not a dietary risk that you had today. Now, I don't know what you have in your cabins, but keep it like what you had here today for lunch and breakfast and dinner. All right, the next one is what? Physical inactivity. And we've already had lots of activity today. The next one is high body mass index. This is a combination of weight and height. And, you know, I underlined the two in red because it seems like many of the others feed into one or the other. So what causes us to have a high body mass index? Maybe number one, eating too much, or number two, having too little physical activity. How about having a high fasting plasma glucose? Definitely that's eating too much, and the pancreas is screaming, it's out of control, it can't control the sugar levels as a response to, as the cells of the body respond to insulin. How about high blood pressure? What is the leading risk factor for high blood pressure? It's sodium. Yeah, and that's what we, yeah, be careful what you put in your mouth, right? You know, I have a baby on the way, and that's going to be our song. Be careful what you put in your mouth. All right. And then we have alcohol use, right? That's dietary. We consume that. We purchase that. And then we have tobacco smoking. Okay? These are the leading risk factors of disability. So we have a small number of behavioral factors that really cause a majority of the problems that we encounter. And so now that you know this, you are well prepared to answer the next question. What interventions are currently prioritized in preventive medicine. Now this might surprise you. It might even shock you. There is a steady progression to use technological intervention using high technology as a priority over simpler and more what? Sensible preventive interventions. And I'm going to give you a few examples of that. And largely behind that we have commercial forces. You might see it on the commercials or in the magazines, and we have representatives visiting doctors. And when they're not visiting you through magazines or the doctors through their representatives, they're visiting your state representative or your national, regional representative by lobbying in Congress, and then we see things moving along. And unfortunately, in many cases, the bottom line is the dollar. All right, this is the 70-30 model that has been proposed by investigators here. And so we have several modalities that can help us to resolve different illnesses, different concerns. And so we have drugs and stents, right, which are more technological. And then we have exercise and smoking cessation, which is more behavioral. And so, according to this author, how do we determine which one gets implemented? Well, if you can't make money on it, it's slow to move. There's a weak industry base. And so things that require exercise or supplementation, there's a 30% uptake because it's cheap. You can't make a lot of money off of it. However, if you can make a lot of money off of it, like the statin drugs, I'm going to talk quite a bit about that, or procedures that involve surgical interventions or stents, we see a 70% uptake in that because there's a high profit margin and it's often pushed. Now we can go one way or the other. Would you rather a supplement or open heart surgery? Yeah, right? Or would you rather take a walk around the track or, get a heart transplant? Yeah, walk around the track, all right? And so here's some data that support that. These are some different procedures, and this little table looks at how these procedures have been engaged by patients. And so we have angioplasty. They'll take a little tube and sneak it through a large artery, and if there's a blockage there, they'll blow it up. Let's see, how much would you pay for that? $80,000 or more. What's the rate of utilization? 70%. A lot of people having stents, right? High profit margin. Now let's look at some things that are a little cheaper and or cost saving. How about your physician when you come in saying, have you considered stopping smoking? Can I refer you to someone? And we see it's cost saving, but only 30% of patients utilize that option. How about cardiac rehabilitation? Helping individuals with exercise and other types of counseling and simple procedures, only 30%. And so this investigator comes up with his 30-70 hypothesis or model. If it's expensive, 70% of the people are going to be directed that way. And if it's cheap and you can do it yourself, then 30% of the people, or with minimal efforts. And so we have to be aware of and read and come to Fit for You to learn about these things. Amen. Now, this was an interesting study referring to the healthcare expenditures in Medicare and the overall quality of care that was given. This is in 2000 to 2001. And this is on the bottom looking at thousands of dollars, and on the side is looking at quality. And what might we see? That the more money was spent, what do you notice about quality? The quality tended to go down. And the less that was spent, the quality did what? Yeah, so this has us scratching our heads. You know, and this kind of fits right in with the 30-70 hypothesis. And even though we might have Medicare paying for it, well, your taxes, which we pay, which we have deductions coming out, you know, we're paying for these services as well that other people use. All right, so I'm going to land squarely on cardiovascular disease. What is the leading cause of, what's that first one? Death. What's the next one? Disability and medical costs. This is what George Bush would call a trifecta, right? A trifecta. What is the leading cause of death, disability, and medical costs? Atherosclerotic cardiovascular disease. It is the leading cause of death, the leading cause of decreased quality of life, and medical costs in the United States. And so this was the American Heart Association website, and they like to talk about cholesterol and the problems that plague us with cholesterol and that plague our hearts and our blood vessels. And it's quite interesting. What do you see at the bottom left-hand side of their web page? Yes, this illustration was sponsored by AstraZeneca. It's good that they let us know that this was supported by them, but it helps us to be aware of the role of the industry. And so, presumably we have bad cholesterol. The LDL, as it's floating around, and it leaves cholesterol and other things that float through the blood vessels, and the cholesterol gets into the wall of the blood vessels, and the vessels get smaller and narrow, and so we can't get blood supply to different parts of the areas. If it's in the heart, eventually you can have a heart attack. If it's in the brain, eventually you can have a stroke. And there are other problems in other parts of the body. And if it's bad enough and we have inflammation driving this process, we have a rupture of the contents floating and causing other blockages and other problems in the body. And so why is this so important? Because there are new recommendations late in 2013, November 2013. The American Heart Association has readjusted the criteria or the classification of cholesterol. You need to hear me. You need to hear me. They have reorganized the criteria for or classification of cholesterol. And so if we look at cholesterol level less than 70 milligram per deciliter, which is pretty good, they say it's an optimal goal if you're at a very what? High risk of a heart attack. Wow. That's the lowest value that you can get, and the description looks scary. I wonder why. Okay, as we go to the next one, less than 100. What is that? Optimal for people with heart disease or diabetes. And then we go to 100 to 129. That's near or above optimal. 130 to 159, borderline high. 160 to 189, high. 190 and above, very high. Do you see anything that says normal on there? Anything that says you're doing okay? Yeah, I wonder why. Okay? And so I'm leading into something. Okay? So the new American College of Cardiology, American Heart Association guidelines, they suggest, we talked about that this was the leading cause of disease, disability, and quality of life, cardiovascular disease. They say if we want to reduce the risk of atherosclerotic cardiovascular disease, and how do we do that? We may use high intensity or moderate intensity what? Oh, you all need to talk to me. The back. We need to use what? High or moderate intensity what? Statin. What's a statin? Yeah, it's a drug. And let's get specific. The HMG-CoA, or 3-hydroxy 3-methyl gluteryl coenzyme A reductase, inhibitor, this medicine blocks a key step in the body that makes cholesterol. And so statins are the short name, but you might know it as lovastatin or pravastatin, anything that has a statin behind it. It works through this method to block the synthesis of cholesterol. And so, wait a minute. So it says we're using statin therapy for use in what? What do you see there? Secondary and what?
Primary.
I had to kind of rub my eyes and see if I see correctly. Last time we were together, we talked about primary prevention. What is primary prevention?
Behavior.
Those are the things that you do at home before you see a doctor. And what can you do at home? You can choose to eat certain foods, or you can choose to do exercise and jumping jacks. That's primary prevention. You're stopping a disease process before you have to go to the hospital to get screened. That's secondary prevention. And then if they have to do open heart surgery or cut off a leg or something, that's tertiary prevention. And when we were together before, which type of prevention would we like to have? Primary prevention. Because it doesn't cost as much money, it's a better quality of life, you have control over your circumstance and your situation. But now, what do you see happening in this recommendation for primary prevention? The use of statin drugs, even at some of the lower levels that were not previously included. And so, what is the rationale? The rationale of this is they looked at randomized controlled trials to compare treatment strategies, and that was the conclusion that they came up with. And so, if something is not in a study, it doesn't exist. That's why we like to, talk to you about putting things in print and crunching numbers so we can share with people the things that are happening at Fit for You. But they say, if we have, new evidence in the future, we can include these in the guidelines. And so, in other words, if I look outside and I see that the sky is what color? Gray. But I didn't do a randomized controlled trial to see that the sky is what?
Blue.
Some of you say gray. Are we together? All right, let's stick with gray. The sky is what color? Gray. But I didn't do a randomized controlled trial to say that the sky is what? Gray. All right, work with me now. And so I'm looking at a gray sky with four of my eyes. My eyes plus my glasses. And I see that the sky is gray, but there's no randomized controlled trial. What am I going to say? The sky is not gray. Let's go back inside. And so, even as this recommendation was being produced, there were new studies that were coming out about different ways to approach this illness, and they say, oh, we know that this is out, but it didn't come out in time to come out in our review, so we can't include it and give you the broader recommendations. Now, you all have to take what? Statins. What do you see here? 2013, that's American College of Cardiology, American Heart Association, blood cholesterol what? Guideline. Produced when? November 12, 2013. Okay, this was published in the journal Circulation. Okay, so what about lifestyle? Didn't we see that, lifestyle was, the leading thing, behavioral factors, things that we can choose to do? Healthy diet or lifestyle modifications were recommended as what? Oh, come on, you all must be sleeping. Healthy diet or lifestyle, fit for you, lifestyle modifications were recommended as what? Background therapy for the randomized controlled trials of cholesterol-lowering drugs. So they're saying, hey, these studies encourage people to do exercise and to eat properly, but they also took statin drugs. And that's what we are encouraging you to do. To do exercise, to eat well, and to take drugs. But then who makes more money when you buy these drugs? But what happens if you adequately control your lifestyle through diet and exercise? Do you need statins? And that's why you're here at 50. I need you to repeat after me. Get serious, about prevention. Get serious, about prevention. If you're not serious about prevention,
It's about prevention.
you're going to be walking to the pharmacy. Yeah. Can you think of a pharmacy? Walgreens, what else? CVS, what else? Rite Aid. Walmart. I'm not giving them any of my money. How about you? Somebody say amen.
Amen.
All right. So, this New England Journal of Medicine article analyzed the impact of these new guidelines. What will be the effect? So, yes, sick people will be on statin medications, but also people who are not quite sick yet but may have slightly elevated cholesterol, or they have an equation to calculate your risk factor to say, you're not sick yet, but based on crunching these numbers, within 10 years, you're going to be sick, so we need to give you this pill. It's true. It's true. And so this article evaluated this new recommendation. And what does it say? The new guidelines would do what? Increase U.S. adults receiving or eligible for what? Statin therapy. It would do what? Increase. Maybe if I was unethical, I would put money in AstraZeneca or Merck or, we can't control where our 401ks go all the time, but some people are about to make a lot of money. Let's see. Most of this increase in number, that is a 10.4 million increase, would occur among who? Adults without what? Are you kidding me? So all of these people now will be taking statin drugs. And if the story ended there, I wouldn't be so sad, but it doesn't. But praise God for Fit for You.
Amen.
Somebody in the back, say amen.
Amen.
I'm going to show you some numbers that we crunched from our 2012 data, and I just picked out LDLs, the quote-unquote bad cholesterol. And if we have all the people that we pulled together, the 42 people that we followed here, we see this was their cholesterol level, about 100. Now this is way over 70, right? And so on. So in the new guidelines, all these people would be, everyone just about, would be on statins. Okay? But then, this was at the beginning, like the first day of fitness camp. And then 2 weeks later, we see a robust decrease in LDL cholesterol. And what percentage of decrease do you see right here? Almost 21%. Did these people have statins? Well, maybe some sick people were on medications, but the bulk of people use the primary determinants of preventive health: diet and exercise. And this was significant. Now, if we broke this down by males and females, there were more females than males. Everyone had a reduction, but only the females were significant. They did a little better. All right, so men, we need you to come up strong this year. If we look at race and ethnicity, all were of Afro descent, and so we stratified them by African American or others of African descent, like Afro-Caribbean or African. And we see that the African American had slightly bigger decrease in their LDLs, but both had a robust decrease in their LDL cholesterol. Let's look at marital status. We have singles, we have married, and a mixture of others, divorced, widowed, and others. And these are the numbers. And so the married folk came out with more robust decreases. Okay? And we stratified it by income. Under 3,000 a month, between 3,000 and under 5,000 and over 5,000. and everyone had a good decrease in their LDL cholesterols, and we see what looks like the biggest decrease were those in the higher bracket. If we look at education, we were evenly split of those who were at least went to college or less, or those who were in graduate school or did postgraduate study. And we see similar robust decreases in their LDL cholesterol. If the groups were working or they were students or retired, they also had big decreases in their LDL cholesterol, but the working folk had a little more. And then, this is a Seventh-day Adventist institution that's hosting Fit for You. So we thought it was interesting, just about everybody was of some Christian backdrop. But if we look at the Seventh-day Adventists versus other Christian groups, the others, other Baptist, Pentecostal, Catholic, they tended to have a more robust decrease. And so this says that the determinants of health work on everybody. No matter where you come from, no matter what your structure, you're working or not, married or not, we see a good outcome. And this is something that each of you can look forward to if you remain faithful. If there's nothing under that bed or that pillow, right? And so you can look forward, this is going to happen to each and every one of you as you remain faithful in this program. And then lastly, I stratified it by age. The mean age was about 59 years for the attendees. And so under 55, we have between 55 and 65, and then over 65. The over 65 are golden, Fit for You warriors had a very strong showing here. So there's no excuse. All of you can benefit from what this program has to offer. And so now let's go back to the guidelines. We saw what Fit for You had to offer. And so now we go back to the guidelines. The ATP was the older generation of guidelines, and then we have the ACC and the AHA. And so this looks at the people who are eligible to receive statin drugs in primary prevention. Remember, primary prevention are the things that you choose to eat or the activities you choose to have in your body. And what group do you see is affected the most? The 60 to 75 group. And if you look at the tan bar, what do you see there? What does the tan bar represent? Predicted risk. That means you don't have it yet. But based on the formula, which appears to be quite reliable, within 10 years, you might have this disease, so you might as well start taking statins right now. Who is it affecting? Our seniors, 60 to 75 years of age. Now, we're not saying, if you're in a condition where you need the assistance of medication, you need to do that. And slowly you can work with your lifestyle, to slowly cut that back. But these are the new recommendations that will be sweeping over individuals who, prior to this, would not have needed to take statin drugs. And even now, as there is an increase in medication and there's a focus of cholesterol, there's some concern even if LDLs are the real cause of cardiovascular disease. I'm just going to plant the seed without going much further. Today, it is becoming more obvious that it is not LDL cholesterol that is directly implicated in CVD, cardiovascular disease, but small, dense, type B particles. What is that? Right? That's a whole other thing. Right? Generated after what? High intake of what? Sugar and? What do you have control over? Yeah. Don't do this. High sugar and what? And so what is the power of primary prevention? It doesn't matter what they come up with. What B particle, A, it could be Z particle, right? Or whatever new methodology, it doesn't matter. If you follow the determinants of health by a healthy diet and a healthy lifestyle, you can enjoy the benefits of those choices. Yes, sir.
Go back to the next one.
Yeah.
Carbohydrates. You talking about breads?
Sorry. Now keep in mind, this says
Processed carbohydrates.
processed carbohydrate. What is that? When something grew up out of the ground, somebody put their hands and messed it with it. They took out things that they shouldn't have been taken out. And so if you have whole wheat, you're taking off different parts. You know, they take out the germ and they sell that separately, and they take out the outer portion and they'll sell that, you know, as Metamucil, you know, and then you have the white starchy part and they make bread with that, you know. And so usually if it's frozen, except for frozen veggies, or microwavable, you know, or a cake or a pastry or something like that, it's highly processed. Especially those things are now have added salt or added sugar or added fat to make people buy it and enjoy it. And so, I mean, processing isn't bad by itself, but usually there are lots of things that come in its trail which you have to read the label to see. So, the beauty of learning in Fit for You is that once you get these tools, you can apply it to whatever the situation. And you need to stay current, you need to learn. I'm going to show you something very surprising, even about lifestyles, in a few slides that you have to be aware. And it says that we have to be continually learning and continually on the cutting edge. But your risk for disease and disability will be much, much less. And even if you have to, maybe you might have a genetic predisposition, your lifestyle choices will delay the consequences than if you did not follow the primary prevention intervention of diet and lifestyle. Okay, so let me give you an example. So we hear a lot about fat, right? And when you go to the store, you should look for low fat. And we have low fat milk and everything is low fat. But then, you know, there's flux in the scientific community about fat. Now look at this, the Mediterranean diet, which has been heralded for the healthy heart. What do we see? The Mediterranean diet has a lot of what? Extra virgin what? What is that? 100% fat. How about this? Nuts. 50% fat. A handful of nuts, you know, every day can help you. But this has a lot of fat. This has a 30% reduction in cardiovascular events. And so if we follow a healthy lifestyle, even sometimes people have a little bit more fat, but they're very, very active and they burn up that fuel, they're doing quite well. And so just stay ahead of the curve. Now let's unearth some new things about diabetes. There's some presenters that will be talking about diabetes during this week. But what is likely to become the next epidemic? Diabetes. Okay. And so this epidemic of diabetes type 2 is largely due to the upswing in obesity. That's one of the simple factors that we talked about. And it is estimated that you know, most individuals in the world, you know, about 10% will have diabetes, but by 2035, how many? 55%, almost 1 out of 2. Yeah. Do I need to do this? 1, 2. I don't wish better on you, my dear sister. 1, 2. 1, 2. 1, 2. And so, yeah, you don't want that? Good. you don't have to have it by making a different choice. And so this is, this is something that is well on its way. However, this reference says that up to what? That's 9 out of 10 people who have type 2 diabetes. It can be prevented through a relatively modest what? Here we go again. It's in your hand. So how can an individual determine if they are diabetic? I'm just going to run over these numbers. You have the A1C. If it's less than 5.7, that's normal. If it's between 5.7 and 6.4, we have pre-diabetes over 6.5. On both of those occasions, by a professional that determines that value, you might be considered a diabetic. Or you might have the fasting plasma glucose test. That's why we said, please do not eat overnight, over 8 hours, and they'll take the blood and look at the levels. If it's less than 100 milligrams per deciliter, it's normal. Between 100 to 126, we have pre-diabetes, and over 126, we have diabetes. And then we have the oral glucose tolerance test, where you drink something very sugary and sweet, and your body has to do the work to bring the sugar levels back down to normal. And so after your blood is assessed, if it's less than 140 milligrams per deciliter, it is normal. Between 140 and 200, it is pre-diabetes, and over 200, that might be considered diabetic. Now watch this. Are you all awake?
Yes.
Yes. Well, this is just looking at your body's response after fasting. Okay, your sugar will go up and down as you eat a meal or based on your level of activity, and your body has to regulate itself. And this standardized procedure says that when you follow this pattern, a normal person has this level. Exactly. Okay, now watch this. What are the American Diabetes Association preventive recommendations for what? Pre-diabetes or? Yeah, what does pre mean? Before. It's like you may have an increase, but you're not quite there yet. And I'm sorry to show you the next slide. How many of you know about metformin? Yeah, I see a few hands and a few heads shaking. Metformin prevention is recommended for, watch this, people with the A1C 5.7 to 6.4. What is that? What is that? It's in parentheses right there. What is that? Pre-diabetes. Yeah. And so you still have a fighting chance to make a choice to change your diet and lifestyle to get that sugar under control. But if you get to some clinicians, before you get a chance to do exercise or come to Fit for You, you'll be on metformin. Just like with cholesterol. If you're calculated to be at risk, before you know it, you'll be on statins. And so I thought it was rather interesting that these major lifestyle diseases tend to converge now in preempting, a preemptive strike. Striking your pocketbook and striking your health with these preventive medications. And some people need them, but we're saying, wow, what about the primary preventive strategies of diet and lifestyle and educating and working with patients? And then, of course, we have the other concerns of impaired glucose tolerance, impaired fasting glucose, a high BMI, persons over 60, or persons who had a previous history being pregnant and diabetic, that is prior gestational diabetes mellitus. All right, but yet the ADA, the American Diabetes Association, recommends behavior what? Change and healthy behaviors. All right, so let's look. How does metformin compare to lifestyle? Are you curious? Do you want to see this? Okay, if your neighbor is sleeping, tap your neighbor. How does metformin compare to lifestyle intervention? Look at this. Over here we have the incidence. This is new cases of diabetes. And so without an intervention, we see that the new cases are pretty high. What happened when a person now is taking metformin? Yeah, there's a decrease. So yeah, we like that. But what do we like even more? Lifestyle has a more robust effect on reducing the incidence of diabetes over years. Okay? Quite powerful, quite effective. Okay? So, from the article, I pulled these numbers out. So, lifestyle has a reduction in relative risk of 58% compared to 31% for what? Metformin. This is with 3.2 years follow-up. And then we have 34% versus 18% with 10 years follow-up. All right, so the power is in your hand. All right, now this is very important. What can be a significant drawback for some persons with intensive lifestyle interventions? Now, this is why we need to be alert and look at the literature. Look at this. I'm going to give you a little background. The ACCORD study had participants with known cardiovascular disease or cardiovascular risk factors and were randomized to what? Intensive glycemic control, that is a goal of an A1C of 6, or standard glycemic control, a goal of 7 or 8 for the individuals in this study. There was an increase in what? Are you all awake?
Yes.
This is a lifestyle intervention. There was an increase in what? What is mortality? Death was observed in a subgroup of participants with the highest A1C levels in the what? Yeah, so you have to be careful. Even though it's natural, even though it's healthy, someone had to analyze this and parse this data out to say, even though I'm walking, if you're doing too much, you shouldn't be doing, that much. We ought to be careful. And in New Start, we have a T. Does anyone know what T I'm thinking about? It's called temperance, right? Balance, right? Being careful with things that are good and avoiding things that are harmful. That is temperance. And so in this subgroup of persons, there was increased mortality. So even at Fit For You, with all these good foods and all of these great exercises, we have to be balanced and not push ourselves too much. And now, so let's describe this subpopulation even further. These were persons with a what? Long duration of diabetes and a known history of what? Severe hypoglycemia. So, if you fall in this category, a long duration of diabetes and a known history of severe hypoglycemia, you still need to do primary prevention, but do it carefully. Rome wasn't built in a day. Have a methodical, long-term approach, right? And you can reap the benefits without the drawbacks. Okay? But the analysis also showed there was no increase in mortality in the intensive group for people who achieved levels of the A1C below 7, or individuals who lowered the A1C how? Quickly after trial, right? Because when you're on a healthy diet and exercise and you're not eating that junk, your body has the vital force or capacity to rebuff or rebuke the disease, and you might find yourself recovering quickly. And you'll be surprised at how you're able to walk the course, or how more palatable the food is because your body is adjusting and changing, okay? And so we need to keep in mind the potential risks of intensive glycemic control may outweigh the benefits in who? Yeah, so even with lifestyle intervention programs that you have the power to choose to participate in, you ought to be judicious, you ought to be temperate, and you ought to be careful. So let's talk a little bit about Fit for You as we look at the general recommendations. So for diabetics, the goal is moderate weight loss of about 7% of body weight. And so in 2012, participants on average lost about 3% of their body weight. And so the average weight of the person in Fit for You was 195 pounds. And at the end of Fit for You 2 weeks later, they were 189 pounds. That's average. Some people were a little more, some people were a little less. And so the recommendation is also 150 minutes of exercise a week. That's between 50 to 70% of maximal heart rate. At least 3 days a week without gaps in between. And so when at Fit for You, we're getting more of that exercise. And so we see the reference, high levels of exercise intensity are associated with what? Greater improvements in A1C and fitness. So we're fine there. And so lifestyle change should also have resistance training, maybe using weights or bands. And so you can go to a workout class that one of our fitness trainers use and have that benefit as well. Reduced calories. Are you eating reduced calories?
Yeah.
Yes, so we have that here as well. How about reductions in dietary fat? Yeah, we have that here as well. And so the USDA, which stands for the U.S. Department of Agriculture, recommends 14 grams of fiber, 4,000. Are you getting lots of fiber?
Yes.
Yeah, we have a last call, not for alcohol, but for what? For salad or fiber. Amen. Yeah, when we have extra salad and we're about to close, we have the last call for salad, so you can get plenty of fiber. And we're doing education here, and we want to empower you. And throughout the series, you'll have coaching sessions with strategies in how you can survive at home, implementing primary intervention. And we have diabetes self-management support. So maybe when you go home, you may want to network with people who live in the same community or not too far away, or email access, or however, just encourage one another and stay connected. There's also a psychosocial role to this. Attitudes related to illness or individuals with depression or eating disorders. There was a young lady that I recall that had no interest in losing weight. Even in the face of the sickness and the disease and the cost of medication. And you know what turned out to be the problem? It was psychosocial. What was it? She said she did not want to lose weight because men would begin to look at her when she lost weight. And she did not want to deal with that emotional stress, so she just decided to stay obese or heavy. That's a psychosocial sort of emotional related factor. And so, with all the things that we have packed into Fit for You, it's hard to have this assessment as a part of it, but we want to encourage you to pay attention to that as well, and to have everything in your favor to have a breakthrough. And so, this was a nice summary slide, and if there are a few things that help with reduction of diseases, and we saw the few things that cause them, I'm going to show you some of them here. If we have public health issues like all cancers, we have lung cancer, cervical cancer, and then we have cardiovascular disease and type 2 diabetes and obesity, we'll see that by implementing one thing, you're knocking out several other risk factors at the same time. And so if we avoid smoking, hey, we can knock out the cancers, cardiovascular disease, and type 2 diabetes. Avoiding alcohol, You can knock out the cancers, cardiovascular disease, and type 2 diabetes, and alcohol. How about eating less? It's helping you in several of these categories. Weight control, low energy density diets, fatty foods that are rich in sugar and so on, that's high energy dense. We avoid those. We want to, if it's in your palate, you can add the Mediterranean diet or increase fruits and vegetables. Notice they help across many different types of diseases. Decreasing sugar, decreasing trans fats, red meats, refined cereals, physically active lifestyle. Look at how many things are helping all at the same time. Pap screening, this will help with cervical cancer. Reduction in sexual partners. These are behavioral choices, not just foods, but where we go and who we're with and the people that we're hanging out with. Okay? Delayed sexual debut will help you with cervical cancer. And so there's a big battle about HPV vaccines, right? To vaccinate someone so that they will not get, in this case the female, cervical cancer or the issues, right? And so we hear a lot about HPV vaccines, but we don't hear a lot about reducing sexual partners or maintaining purity or character education. We need all hands on deck. And so, but the HPV vaccine is highly effective, right? And when we reach marrying age, some people do lie. When they say, oh, I didn't have this many partners, or I've been faithful, and then you take the blood test, and then you find out other things. And so, the HPV vaccine is good, but we're talking about in context of the simple and the effective, other simple and effective strategies that we can employ. All right? These are things that are not sufficiently prioritized. Smoke-free spaces. Okay? And the U.S. has done well with that. We have raising tobacco prices. The U.S. has done well with that. Other countries struggle. Air pollution control. Right? This is environmental. That can affect us. Right? And then we have the affordability of food. Banning trans fats. New York City has been, pushing that area. And then others would call them the nanny state, right? Because they're banning fat and other things. Okay? Serving size in restaurants, decreasing sugars, sexual attitudes, cultural change, right? And in place of this, these are the dubious technological exchanges that we have. Genetic testing. Right? So I can do genetic testing for a certain type of cancer, but I can also avoid the risk factors so that my genes don't play on the environment. So, but we like the fancy, testing, right? And even for lung cancer, there was a recent recommendation to do low-dose CT scanning. Well, CT scans increase your radiation, and you can, over time, have cumulative exposure, and it can increase your risk for some cancers. How about telling people to stop smoking instead of having them pay lots of money for CT screening, right? We have the HPV vaccine, and we talked about that. Statins, we talked about that. Education through diet and lifestyle. We talked about diabetes type 2. Heavy dose, even pre-diabetes, of metformin and other drugs. But lots of things that you can do. And even with anti-obesity drugs. People say, oh, it's in my genes. Well, stop eating, stuffed crust pizza with, what else? Ice cream and, all that stuff, right? But, some organization would say, before you come into our restaurant, just take a statin pill and you can eat whatever you want, right? Before you go into McDonald's or Pizza Hut. But these are technological, expensive interventions that have side effects, and the other choices, you can just choose to be moderate or avoid and have control and experience the benefit. So I want to encourage you before I sit down. I want to encourage you to live a life of prevention. And, if you want to take, statins and metformin and other stuff, you've been educated and the power's in your hand. But if we can close with a repetition or a chant, if you will. Repeat after me. Get serious.
Get serious
About prevention.
about prevention.